Welcome to Roadmap to Residency. Today we are diving into calcium and bone disorders for the United States Medical Licensing Examination, Step 2 Clinical Knowledge Exam. This is not your typical lecture. Instead of teaching you the entire topic from scratch, we are going to focus on question stems you will actually see on test day and the strategies to pick the right answer every single time. We will cover hypercalcemia and hypocalcemia, primary hyperparathyroidism, osteoporosis screening and treatment, and Paget disease of bone. If you find this helpful, please like and subscribe, and check out our expert tutors and residency advisors at roadmaptoresidency.com. Let us get started. Before we jump into cases, let us establish what you will gain from this session. First, you will learn to recognize classic question stems. The test writers use predictable patterns, and once you know them, the diagnosis becomes obvious. Second, we will focus on elimination strategies. Often you can narrow down to two choices quickly. Knowing how to pick between them is where points are won or lost. Third, you will master the diagnostic algorithms. Questions often ask for the next best step. Knowing the correct order saves you from trap answers. Finally, we will drill high-yield buzzwords. These are the phrases that should immediately trigger a diagnosis in your mind. For the foundational knowledge, review the endocrine and musculoskeletal sections of first aid and the relevant chapters in your preferred question bank. This video assumes you have that baseline and helps you apply it strategically. When you see a calcium question, your first mental step should be to categorize it. Ask yourself, is the calcium high or low? Hypercalcemia presents with the classic mnemonic stones, bones, groans, and psychiatric overtones. Think kidney stones, bone pain, abdominal pain with constipation, and confusion or depression. The two most common causes are primary hyperparathyroidism and malignancy. Hypocalcemia presents with neuromuscular irritability. Think tetany, Krvoštek sign, which is facial twitching when you tap the face, Trousseau sign, which is carpal spasm with blood pressure cuff inflation, perioral numbness, and seizures. Next, think about the parathyroid hormone level. This is critical for narrowing your differential. If parathyroid hormone is high with high calcium, you have primary hyperparathyroidism. If parathyroid hormone is low with high calcium, think malignancy or granulomatous disease producing excess vitamin D. If both are low, think surgical hypoparathyroidism. If parathyroid hormone is high but calcium is low, think vitamin D deficiency or chronic kidney disease. This framework helps you immediately narrow your differential when you read a stem. Let us drill the buzzwords that should trigger immediate pattern recognition. For primary hyperparathyroidism, the classic patient is often asymptomatic but discovered to have hypercalcemia on routine labs. They may have a history of kidney stones, osteoporosis, or non-specific symptoms like fatigue. The parathyroid hormone level is inappropriately elevated. For hypocalcemia, remember the neuromuscular findings. Perioral numbness, carpopetal spasm, positive Krvoštek sign where tapping the facial nerve causes twitching, and positive Trousseau sign where a blood pressure cuff causes carpal spasm. The electrocardiogram shows prolonged QT interval. For Paget disease of bone, think of an elderly patient with bone pain, especially in the skull, spine, or pelvis. The key lab finding is markedly elevated alkaline phosphatase with normal calcium and phosphorus. They may have hearing loss from skull involvement or high-output heart failure from increased bone vascularity. Commit these patterns to memory. They are tested repeatedly. Read this stem carefully. This is your classic primary hyperparathyroidism presentation. The key buzzwords are asymptomatic hypercalcemia discovered incidentally, a history of kidney stones, and an elevated parathyroid hormone level. Notice the calcium is only mildly elevated at 11.2. This is typical for primary hyperparathyroidism. Malignancy usually causes more severe hypercalcemia, often above 14. The parathyroid hormone being elevated in the setting of high calcium is the diagnostic giveaway. Normally, high calcium should suppress parathyroid hormone. When it does not, you have autonomous parathyroid function. Now, before I reveal the answer choices, think about this. The question is asking for the next step in management. This is not asking you to confirm the diagnosis, as we already have that. This is asking whether this patient needs treatment. This distinction is critical for getting the question right. Let us break down why the answer is surgical referral. The algorithm for primary hyperparathyroidism management has clear criteria. First, confirm the diagnosis. We have hypercalcemia with elevated parathyroid hormone. This confirms primary hyperparathyroidism. No additional testing is needed for diagnosis. Second, determine if surgery is indicated. For symptomatic patients with kidney stones, bone disease, or neuromuscular symptoms, surgery is always indicated. For asymptomatic patients, surgery is recommended if they meet any of these criteria: age under 50 years, calcium more than 1 mg per deciliter above the upper limit of normal, creatinine clearance under 60 milliliters per minute, bone density T-score worse than -2.5 at any site, vertebral fracture, or prior kidney stones. Our patient has a history of kidney stones, which automatically meets criteria for surgery. The test writers love to include trap answers like observation, bisphosphonates, or imaging studies. Remember, a sestamibi scan helps localize the adenoma, but does not change the decision to operate. The decision comes first. Correct answer: refer for parathyroidectomy. This stem is packed with clues. Let us identify them systematically. The patient is 2 days post-thyroidectomy. This is the key timing that tells you the diagnosis immediately. The parathyroid glands sit right behind the thyroid and can be damaged or devascularized during surgery. She has perioral numbness and finger tingling, which are classic symptoms of hypocalcemia. The positive Chvostek sign, where facial nerve tapping causes lip twitching, confirms neuromuscular irritability. The calcium of 6.8 is severely low. Normal is 8.5 to 10.5 milligrams per deciliter. Now think about what the question is asking. It says most appropriate immediate treatment. This tells you the patient needs urgent intervention. With symptomatic hypocalcemia and a calcium this low, you cannot wait. The distinction between oral versus intravenous calcium replacement is critical here. Let us break down this case. First, recognize that symptomatic hypocalcemia is an emergency. When you see perioral numbness, tetany, or positive Chvostek or Trousseau signs with documented low calcium, you must act immediately. The danger is that severe hypocalcemia can progress to laryngospasm, causing airway compromise, seizures, or fatal cardiac arrhythmias from prolonged QT interval. Second, choose the right treatment. For acute symptomatic hypocalcemia, the answer is always intravenous calcium gluconate, not oral calcium, not vitamin D, not observation with repeat labs. Calcium gluconate is preferred over calcium chloride for peripheral intravenous administration because chloride is very irritating and can cause tissue necrosis if it extravasates. Wrong answers the test writers love to include: oral calcium carbonate, oral calcitriol, checking magnesium before treating, or observation. While you should check and replace magnesium, this should not delay calcium replacement in a symptomatic patient. Correct answer: intravenous calcium gluconate. Let me share some high-yield management pearls for hypercalcemia. For acute severe hypercalcemia, meaning calcium above 14 or any symptomatic patient, the first step is always aggressive intravenous fluid resuscitation with normal saline. Volume expansion increases renal calcium excretion. Give 2 to 4 liters in the first 24 hours if the patient can tolerate it. After adequate hydration, add intravenous bisphosphonates such as zoledronic acid. This inhibits osteoclast activity and provides sustained calcium lowering over days to weeks. Calcitonin works within hours, but the effect wears off quickly due to tachyphylaxis. For hypercalcemia of malignancy, remember that parathyroid hormone will be suppressed. The most common mechanism is parathyroid hormone-related peptide secretion by squamous cell carcinomas. Breast cancer and multiple myeloma cause hypercalcemia through different mechanisms involving bone destruction. The board exam loves to test whether you know to hydrate first before giving bisphosphonates, and to distinguish parathyroid hormone-mediated from non-parathyroid hormone-mediated hypercalcemia. This question tests your knowledge of osteoporosis screening guidelines, which is heavily tested on the boards. Let us analyze this patient. She is a 52-year-old postmenopausal woman. She has a family history of hip fracture in her mother. She has no other major risk factors listed. The question asks for appropriate screening. This means you need to know when to screen for osteoporosis with bone density testing. The key factor here is her age. She is 52. The standard recommendation is to screen all women at age 65 or older, but there are exceptions for younger postmenopausal women with risk factors. Think about whether her risk factors are enough to warrant earlier screening. The fracture risk assessment tool, sometimes called a risk calculator, can help determine who needs earlier screening. This is a common board question format. A relatively healthy patient who may or may not meet screening criteria based on guidelines. Let us review the screening guidelines and apply them to this patient. First, know the standard recommendations. The United States Preventive Services Task Force recommends screening all women at age 65 and older with dual-energy X-ray absorptiometry. For postmenopausal women younger than 65, screening is recommended if they have risk factors that increase their fracture risk to the level of a 65-year-old. Second, apply this to our patient. She is 52 with early menopause at 48 and a family history of hip fracture. These are risk factors, but they alone may not push her 10-year fracture risk high enough to warrant immediate screening. The correct answer is to recommend routine screening at age 65. Some guidelines suggest using a risk assessment tool to calculate her 10-year fracture probability and screen earlier if it exceeds a certain threshold. But without additional risk factors like smoking, low body weight, or personal fracture history, most women at 52 can wait until 65. Remember these key testing pearls. Parathyroid hormone interpretation requires knowing the calcium level, fragility fracture equals osteoporosis, regardless of bone density, and isolated elevated alkaline phosphatase with normal calcium is Paget disease. For comprehensive review, check the endocrine and rheumatology sections of First Aid and work through your question bank. If you found this helpful, please like and subscribe. Check out our expert tutors and residency advisors at roadmaptoresidency.com. Good luck on your exam.